So I'm going to talk today on lactation challenges that are faced by the GP. It's a pretty broad topic, and as in the introduction, I'm a private practitioner in general practice, and I also have an interest in lactation. As far as conflicts of interest, I have none to declare. So fortunately, Nicole's already covered quite a lot about the anatomy and physiology of breastfeeding, but it's really important just to understand a little bit about initiation of lactation. So I've left these slides in as a resource, but I'm not going to spend too much time on them. But essentially, there's breast development during the pregnancy is important. The placenta is expelled, and that sets up a hormonal cascade which leads to the milk coming in. And then with mature milk production and supply, you get the autocrine control that Nicole's discussed earlier. So it's really important that the breast keeps emptying, even if the mother's unwell and able to feed or the baby's sick. The baby can be fed adequately, but if we don't keep that mother emptying the breast, she's going to get a build-up of that hormone feedback inhibitor of lactation, and that's going to interfere with supply. So I just thought I'd start with a case study on undersupply, which is the sort of patient that commonly I see in practice. So this lady I'm going to call Mrs. IN, and she presented with her baby Crystal. At this stage, I was fortunate enough to have a lactation consultant working in my practice, so she'd already done most of the history for this patient. But Crystal presented at 2 weeks of age with her mum. She was the first baby in the family. The community nurse was concerned about low weight gain. She still was below her birth weight at 2 weeks of age, and her latch was quite poor. In her pregnancy history, Crystal was born at 37 weeks. There wasn't any particular reason for that. It was a normal delivery. She delivered out of area because she'd only just recently moved to the area and she'd had her antenatal care at another hospital. And Crystal weighed 2,500 grams. In the early neonatal period, Crystal had jaundice, which was treated with phototherapy. But she was discharged relatively early, I think after about 4 days. Crystal's mum had small breasts, but they looked quite normally shaped, but she had very definite inverted nipples, and she fed using nipple shields. And her baby was really very sleepy. So at the first visit, there was obviously a lot to cover, and very many factors between that mother and infant couple that could have led to this problem with decreased milk supply and poor weight gain. So at the first visit, this was the management that we came together with Mrs. IN to decide for her and Crystal. We decided that she should feed very frequently, every 2 hours during the day and 3 hours at night, and she was to wake the baby for a feed if the baby slept through. And I know that's really difficult advice to give to a new mum, but if she can just do it even for a few days, it makes a big difference to the supply. She was to have skin-to-skin contact with her baby just to help with the attachment problems as much as possible. And if she observed any cues that Crystal was hungry, she was to put it to the breast straight away, regardless of the time period between the last feed. Wherever possible, we had the mother express after feeds to stimulate the breast and to provide milk for a complementary feed. Now, Nicole's touched on the reasons that we might do complementary feeding. So with this particular baby, because the birth weight was low and she wasn't back to her birth weight by 2 weeks, she clearly was failing to thrive. And she was really very sleepy at the breast. She could only feed for a couple of minutes before she dropped off and fell asleep. So this baby is sort of the type of baby that's actually quite weak and feeble. So we have babies that are crying all the time and their mothers often bring them in, but we have to really watch out for those weak, feeble babies because they're not going to feed well unless they're given some nutrition and some energy to become a little bit more robust. So we decided with Crystal that she would have a comp feed of 60 mils, which was offered after each breastfeed. And where possible, that was to be express breast milk, but formula could be offered if there was not enough milk to provide. And because of her inverted nipples, we decided to deliver that through a 5-gauge feeding tube attached to mum's finger and just using a syringe. And the shields were continued at that visit. So we decided we'd see Crystal and her mum every week for the first few weeks because we were quite concerned about this baby. So at the second visit a week later, Crystal was much more alert, she was feeding a lot more often, and she had a really good urine and stool output, and we'll talk about what's normal later. She'd gained 160 grams of weight, and we were actually able to have a look at a feed again, show the mother how to latch the baby without the shield and have a successful shield during the visit. And we actually used a breast pump to draw the nipple out a bit before we tried to attach the baby. And so we decided that at home the mother would try and feed Crystal without the shield, but do it really early at the first sign of hunger cues. But if Crystal was to wake really distressed or they were out visiting people, just keep going with the shields. And we decreased the volume of the complementary feed to 40 mils per feed. So at the third visit, that was a bit of a shorter visit, fortunately. Mum was no longer needing to use the shields. She felt that her nipples were beginning to actually elongate and become a bit less tethered, and her breasts were feeling full just before a feed. And again, Crystal's weight gain was satisfactory. So we ceased the complementary feeds and got it back again in the next week. And at the fourth visit, everything was fine. So we just decided we'd see her again when she was due for her immunisations. So that was a case with a really good outcome because Crystal was able to feed until she was 18 months old. It's probably a slightly unusual case in that she had a really well-motivated mum who was well-educated in the benefits of breastfeeding and was really committed to continuing. But it's quite a good case because she didn't actually require any medication. She was able to increase her supply just with lots of expression. And by the end of her 18 months of breastfeeding, her nipples actually looked fairly normal and she was able to breastfeed her second baby without any medical interventions at all, which was a really good outcome for her. So I've got some handouts also in those folders because there's a lot to cover. And just about everything that isn't covered in my talk and Nicole's talk is in that handout at the front desk, which is the South West Sydney Local Health District guidelines for breastfeeding. So fortunately, as we're fairly time pressed in general practice, we already have a knowledge of the mother's history in most cases, but there's a number of medical illnesses, medications, and issues with pregnancy, labour and delivery that can interfere with the mother establishing a good milk supply. So we need to take a good history. We need to have a look at the pieces of paper that come back from the hospital that tell us whether it was a normal delivery, whether it was a Caesar, whether there was any postpartum hemorrhage. We need to just investigate the mum's past experiences of breastfeeding and what people have told her about it. Be wary of any mental health or social factors which might interfere with supply. We need to examine the mother, look at her nutritional status. Anorexia is one of the causes of breast hypoplasia. We need to do a breast examination and nipple examination and have a look just to make sure there's no scars or other signs of breast, chest or auxiliary surgery or procedures. So there's quite a lot of normal variations on breasts that mothers might present in the antenatal period with or at a pre-pregnancy counselling session. So I'll very quickly just touch on those, and you can read the rest of it in the handout really. But with small breasts, the mother's breasts are smaller than usual. Sometimes they can be younger patients. The breasts actually keep growing up until 30 or when you have your first baby. So often there's quite a lot of breast proliferation that continues into the second trimester. So it's a good idea if mum's breasts are small and she's concerned about it to say, like, come back in the second trimester and we'll just see how things are going. But the mother with small breasts should be able to feed with no problems as long as it's not true hyperplasia. So Nicole's touched on hyperplasia, and a mother with breast hyperplasia will produce milk, but there may be a genuine deficiency of tissue and undersupply. So it's really important if we can get this mother motivated to breastfeed, even if she's not able to fully breastfeed and has to use some formula as well. But the most important thing is if you see a mother with breasts like the lady in the picture, she's obviously got aplasia on one side, hyperplasia on the other side. So telling her to drink more fluids and rest a lot, it's not going to work and she's going to get really frustrated. So we really want to identify those mums, and they're people that probably should be educated in ways of complementary feeding the baby before they leave hospital, because those babies are at risk. Lots of mums have differently shaped breasts, and that's quite normal. It's just a variation on normal. Sometimes you can have one normal breast and hyperplasia on the other side, and that mum would be able to successfully breastfeed because the normal breast can really supply all the needs of the infant if necessary. Some mums can have a syndrome called Poland syndrome. It's quite rare, but they usually have an underdeveloped hemithorax, and that will include the breast. So we just need to reassure that mother that she should be able to successfully breastfeed. And the other group that are a bit concerned are the ladies with large breasts. They'll have no problem with supply, but they might have more discomfort, and it might be more difficult for the baby to feed without its nose getting blocked. So they may need someone to watch them feed and just make sure everything's going okay. Hypermastia is the presence of accessory mammary gland tissue or nipples, and it can occur anywhere along the milk line, which runs from the axilla to the groin. So probably a lot of people have seen that, and it's just important to remember that that is breast tissue, so you can get blocked ducts and leakage from these accessory nipples and malignancy in the tissues, just like any other breast tissue. Inverted nipples, so this was a fairly similar picture as what we saw with Mrs. IN. Hopefully that would be identified during pregnancy, and there would be a plan for extra support sort of soon after the delivery. You can use a nipple puller, which is a little gadget you can buy from the pharmacy, or you can make one by cutting off the end of a 20mm syringe and turning it back to front so that the non-sharp side is against the mother's breast. We don't usually use those so much during the pregnancy. People can use them before they plan to get pregnant if they want to, but we can use the nipple puller and pump to shape the nipple before a feed. One of the other things people can sometimes buy is breast shells, but there's a bit of evidence that suggests if we fuss too much about inverted nipples while people are pregnant, that they get anxious about it, and that might actually make them less likely to breastfeed. So giving them lots of support immediately after the baby's born is really the mainstay of treatment there. These mums can use a nipple shield to help attach the baby, but nipple shields do interfere with the sensory feedback to the nipple, so if we can avoid using them, it's better to get by without them. And of course, surgical and cosmetic procedures were covered by Nicole. We do sometimes investigate mothers with undersupply, mainly full blood count, thyroid function and prolactin, and we mainly only do that if it's suggested in the history. So a mum who's had a big PPH and we might be worried about Sheehan syndrome, we might do some investigations. I could probably add a pelvic ultrasound for someone who has a history that is suggestive of retained products of conception, but otherwise we wouldn't bother with that. And if the baby's very sleepy, a urine culture and a bilirubin. So I won't go through all of these, but these are the sorts of things that we like to find out about the baby's history. So particularly any separations from the mum, and then currently we need to know the feeding behaviour and the frequency of feeds and the frequency of wet and dirty nappies. So examining the baby, we need to have a look at the baby's colour, and we need to weigh the baby, and preferably a bare weight, and if there's any sort of concerns about the weight, make sure we're looking at a WHO chart, which is more suitable for breastfed babies. We're obviously looking at weight, height and head circumference as a total picture. We're looking at the oral anatomy of the baby. That may have been assessed in hospital. If you're time poor, you can ask whether the paediatrician checked out the baby. But probably the main thing to look for is to make sure there's no tongue tie or upper or lower lip tie or cleft palate. And then you just want to sort of have a look at the baby to see that generally the tone's good and there's no sign of any congenital abnormalities or neurological problems. So one of the most important things is actually to watch a feed, and that's maybe something you don't have time to do, and if that's the case, that's where your lactation consultant is a good resource, because he or she will be trained in how to assess a proper feed. But I've just added what we would be looking for in a normal feed. So mum should be really relaxed and confident and calm about what she's doing. She shouldn't have any shoulder or neck pain. You can get a little bit of nipple pain with the first few sucks, but that should settle down after that. And there should be no evidence of misshapen nipples or trauma after the feed. We talk about the chin to breast, chest to chest. It's a little line that helps us remember good attachment. And basically, there's no clear rules because all mothers have different shaped breasts and all infants have different shaped mouths. But we like to see a wide mouthful of breast with a clear nose, and I'll show you some pictures of those on the next slide. And the infant should be sort of close and parallel to the mother's body, not sort of falling away or at an awkward angle. Early on in the feed, the baby should look calm and relaxed without any clicking, pulling or arching away from the breast, and we should be able to tell when the letdown occurs by the change in sucking pattern. The baby shouldn't tire too early, and it should look satisfied and relaxed and fall asleep after the feed, and mum should be able to tell that the breasts are more empty compared with before the feed. So you can see in that picture how the baby has a nice wide mouth, and you can see that the nose is clear there and not blocked by the breast. And the main way that you can clear the nose is to get mum to tuck the baby into her hip, so nice and close at the hip, and then the nose falls free. So one of the main reasons that mothers wean early is a perceived insufficient milk supply. And this is a situation where the mother feels the supply is low, and I'll go through a slide later as to what sort of things mothers worry about, despite the fact that we feel that the infant is growing well and there's no concerning signs in the infant. So it's really important to ask the mother what her concerns are, because otherwise, our mindset is like, okay, I've got to exclude anything serious, and next I've got to see if the baby's normal and the mum's normal, and then I can reassure them that everything's okay. But mums are pretty concerned that we might think their questions are pretty trivial. They might have worries like, are my breasts going to look funny after I finish breastfeeding, or is this going to interfere with my relationship with my partner, or they may be concerned about a number of other things that we haven't thought about. So if we don't actually find out what's worrying the mother or what's making her think that the supply is not going well, we're going to miss the point of it all. And not all mothers are happy to address all issues. For instance, a mother might have to go back to work early. That just might be a financial constraint, and there's nothing that we can do about it. So we have to work within with the issues that the mother's willing to address and the resources that she has, and come up with a plan of management that empowers her and also try not to over-medicalise the feeding experience for her. So these are the important things we need to know about what's normal in a baby. And so adequate weight gain, we want the baby to have lost no more than 10% of its birth weight. We want to see the baby back to birth weight by 2 weeks. The average weight gain is about 500 grams per month. So we're really happy if we see 150 grams a week, just as a rule of thumb, and we get a bit worried if we see less than 105 grams per week. Adequate stool and urine output, we should be seeing 6 to 8 wet cloth nappies or 5 to 6 very heavy disposable nappies, and the urine shouldn't look concentrated. So stooling pattern really varies in babies, and basically from day 3 to 30, about 3 stools a day is usual, but we'll accept 1 if it's a really voluminous, loose, pale yellow stool. But after 8 weeks, the frequency of stooling reduces quite a lot, and you can go up to 10 days even sometimes between stools. So you have to have a look at the baby. If a mum, I think about 20 days is the longest I've ever had a mum bring a baby in, and I did get anxious and do some further investigations. But basically the baby's tummy is soft, they're passing wind, and the stool is loose when it comes, and everything else seems fine. You can usually reassure the mother about that. We like the baby to have periods of looking alert during the day and showing normal feeding cues like sucking its hand and fidgeting around looking for the breast. The baby should be settled after most feeds and hopefully will wake spontaneously for a feed. And a normal baby feeds 8 to 12 times a day, and most people who haven't had children would think that that sounds like a lot, but that's what normal is, and we need the baby to be feeding that many times a day to get adequate suckling to maintain a good supply. So these are the things that mothers mistakenly interpret as insufficient supply, and if everything else is normal, as per the normal baby slide, we can reassure mum that she doesn't have to worry about things such as the milk looking watery, the breasts not being as soft as they were immediately after the baby was born, and the baby sleeping less. And one of the big things is that often helpful relatives will suggest that mum has a rest and offer the baby a bottle, and if the baby guzzles down a bottle of milk after a feed, that actually is not a sign that the baby's hungry. So what are the real causes of undersupply? So it's mainly poor attachment at the breast and not emptying the breast adequately. And that can be because the feeds are not frequent enough, because there's reduced sucking due to introduction of formula and dummies. So one of the issues with giving the baby a bottle of formula is that cow's milk actually has a different fat and protein composition than breast milk, and although it's manufactured to be more like breast milk, generally the baby actually will feed less frequently if it's given formula, because cows are actually meant to be calves are frolicking in the paddocks, and they don't feed as often. They can't come and find their mothers as often, whereas we're meant to be sort of close to our infants and carrying them around. If the baby does have a bottle of formula at night, it's not really surprising if the mother's supply is going to drop off. And if mum wants to keep doing that, then really you've got to suggest that if she wakes up in the middle of the night, she does express some milk off. But we really want to discourage that if we can. So separation from the mother, particularly in the first hour after the delivery, is an issue. So it's really important with mothers who have seizures to get them together with the baby as soon as possible afterwards. Sleepy babies who are unwell or jaundiced or premature. Mastitis can temporarily interfere with supply, medications and other medical conditions, and baby factors such as tongue tie and congenital abnormalities. So the mainstay of management of undersupply is actually non-pharmacological, and it takes time to educate a mum on what increases or decreases supply of breast milk. So that's why it's actually really important with the Baby Friendly Hospital initiative that hopefully mothers will have some of this education before they hit our doctor's surgeries, and we're just reinforcing information they've already seen. It's really useful to give handouts because there's lots of information that we're trying to give out to the mums. So at the end of the slide there's some resources. The Health Pathways has got some links to some good handouts that you can give mothers, and there's also some handouts in that Southwest Sydney documentation as well. So basically we want lots and lots of feeding, lots of contact with the baby, skin to skin, especially if the baby's refusing to take the breast. And another thing that you can try is switch feeding, where you start feeding on one breast, offer the second breast and go back to the first breast again, and that's really useful for mums who have limited time to express or can't afford a breast pump. But expressing by hand is fine if mum's got time to do that. That works just as well. So if we're worried about the baby because it seems to be sick or not gaining weight, or the mother's breasts are abnormal, we need to actually follow those babies up early. They're not the ones that you sort of send home on early discharge without follow-up. So if babies are very sleepy or their weight gain's really compromised, we would offer complementary feeding, but we offer it after the breastfeed and give express breast milk wherever possible. And if there is true deficiency in breast tissue, again, we need to actually have a plan for how that mother will give the complementary feed, and Nicole's touched on that, but that's a supplementary nursing system. It's not so good if the mother has inverted nipples because the baby's already having trouble latching on, but for a mother with underdeveloped breasts who has a more normal shaped nipple, that works really well. So we'll get asked a lot about galactagogues. Many mothers will come in, they're already using some herbal treatments or some brewer's yeast or something like that. And actually the medical evidence for galactagogues is not all that great. There's some protocols that can be found online for the Academy of Breastfeeding Medicine, and I really encourage everyone to have a look at what sort of protocols are there. They get changed and updated every few years, so last time I looked at them, there was a lot on motilium. This time, they were sort of hedging their bets a bit and saying we really need more research. But what I can tell you is that motilium is commonly used. Up to 5% of admitted mothers in Australia are given motilium in hospital, and obviously we give plenty of it out in general practice as well. So although there are concerns with cardiac issues and it's being used off licence, I think there's enough evidence around to suggest that it is actually very safe to be used in lactating mothers, and experts in lactational pharmacology such as Tom Hale and Professor Rick Day consider it to be safe, and it was listed to be used in the Australian Medications Handbook as a galactagogue, but then the drug company pressured them to take it out again. So we usually start at 10 milligrams 3 times a day, and we increase that to 20 milligrams 3 times a day if there's no response. And then when we do go to reduce it slowly, after we're happy with the supply, we reduce it each week and reassess the weight each time. And if we have a problem with the baby losing weight again, we just go back to the dose we were on before. So the main other side effects, mums might complain of a dry mouth, headache and tummy pains with that one. The other thing that you hear a lot about is fenugreek. There isn't a great deal of evidence, in fact pretty well no evidence that that's helpful other than by placebo effect. But there's no harm in people using it, and sometimes, if you're feeling, we feel it's safe even if it's not that effective. The important thing to know about that one though, if mum tells you she's going to use it, is that there's a cross allergy to peanuts and chickpeas, so those mums obviously can't try that type of treatment. So another thing that I've been asked to talk about is oversupply, but and this is a statue that I found in Thailand recently. I couldn't actually find out the name of this lady, but there's also similar statues in other cultures, and that's the sort of lady that every milk bank in Australia wishes would come in the door. This lady here, that came off a blog. This lady had actually sent that picture of her breasts. You probably can't see it, but the tattoo says "Count your blessings," and she said, "These are my breasts. They're red, they're sore, they won't go away. Can anybody help me?" So basically, full breasts are quite common when the milk comes in. Prolonged oversupply is very uncommon, and when I was preparing for this talk I really only found a few references in textbooks and a few research articles about that. And the more sort of serious problem that I guess lactation consultants see is engorgement, but that occurs in the early postpartum period, so often we don't see it in general practice because those patients traditionally go back to the hospital that they had delivered to. Because the milk comes in faster with multips, those babies sometimes end up with fast flow, and milk's coming in a bit letting down a bit faster than the baby's actually able to deal with it when it's very young. So the main problems with rapid ingestion of large milk volumes is that you get an overload of lactose in the small bowel, and those babies can be windy, have abdominal pain and frothy stools, and sometimes the baby will cough and chomp on the nipple just trying to close off the flow. So the way that we deal with a fast flow is basically to suggest that the mother is reclined or semi-reclined with nursing. That way when the milk's shooting out it sort of falls back towards the breast rather than hitting the back of the baby's throat and making it cough. And we suggest one-sided feeding, so we're using that feedback inhibitor of lactation to sort of slow the supply down a bit. So the difference between engorgement and normal oversupply is that the breast is actually swollen and filled with interstitial fluid, as well as milk that's blocked and can't get out. So the mother has discomfort due to the breast being over full and due to edema. The breast looks swollen and enlarged, and the nipple can be stretched flat, and the baby can have trouble latching on. So the problems with this particular mum is that the milk won't flow, the letdown won't come. And if the milk is not removed, the mother gets more uncomfortable, and then the milk supply fails because there's milk stasis, and the mother's more likely to get mastitis. So to treat engorgement, we usually optimise attachment. We get the mum, we prevent it by getting mum to feed frequently, and rooming in and feeding on feeding cues all help. If the mother's had engorgement, we get her to wake the baby again if it sleeps for more than 3 hours. If the nipple's very flat and misshapen, we get mum to express enough milk off first before latching the baby. And some mums find leaning over into a basin of warm water helps get the milk flowing, but heat generally makes it feel a little bit more uncomfortable, so we try and avoid that and use ice instead. So if mother doesn't have an ice pack, a nappy that's just wet and stuck in the freezer, a disposable nappy works really well as an ice pack for a breast. Cabbage leaves tend to aid discomfort, and they may have an effect on supply. And we usually get the mums to massage with a firm pressure towards the nipple during expressing. And we don't want to pump too much because that's going to make more milk. And if it's really severe, there is a technique called block feeding, where you get the mother to feed on the one breast multiple times before swapping to the other breast, and that will sometimes help cut down supply. Also, there's an occasional time when mothers have engorgement where it's not appropriate for them to feed the baby, so that might be if there's been a stillbirth or the baby's been put up for adoption. There is a medication called cabergoline, and the doses of that are actually in that handout as well. So one of the common things that we see in general practice is mastitis. So that's characterised by a tender area of local erythema. It affects 3 to 20% of women, usually fairly early in the postpartum period, around 6 weeks, and less common by 12 weeks. And it's not necessarily infective, so we usually give the mother strategies to try and empty the hardened area But if that's not improving or there's signs of nipple trauma, we start antibiotics. And hopefully mums have been educated on that. Mothers feel really terrible when they have mastitis, so one of the things that they say is, I've never felt worse. They're really worried they've got a serious illness, they're worried that the milk's not safe, so it's important that we really reassure that mother that it's safe to keep breastfeeding and that she must keep breastfeeding to prevent an abscess. If she really wants to wean for some reason, try and get her through the acute episode of the mastitis, and that can be discussed later. So there's a lot of risk factors for mastitis, but the main ones, poor latch, not emptying the breast properly, and nipple trauma. For the audience here, if you, some people might have had that experience of going to a conference, trying to feed the baby in an enclosed conference chair, and then getting home and realising the next morning you've got mastitis. So it's really important if people are feeding in cars and things like that, that they sort of look out for it. So we know it's infective when there's high temperature, like 38 degrees, lots of systemic symptoms, and the most common organism is Staph aureus. We don't usually need to do investigations unless there's atypical features or we're suspecting MRSA. You can do milk culture, similar to collecting a urine. You just clean the breast with an Alco swab and discard the first little bit and then catch some in the jar and send it off for culture. So emptying the breast is the first mainstay of treatment. You start the feed on the affected breast every time until it feels more comfortable. Position the chin, or if you can't do that, the nose towards the blockage. Massage the hardened area. If the breast is really swollen, you can try and massage towards the axilla as well, and that helps also with engorgement, just to try and get some of that swollen fluid towards the axilla. But if feeding is impossible, you have to empty the breast by hand or by pumping to avoid an abscess. Reduce discomfort by using cold packs, avoiding tight clothing, and analgesia such as paracetamol or ibuprofen is safe. Reassure the mum that it does seem to settle down after about 12 weeks. Try and get the latch working properly so that there's no nipple trauma, and make sure you reinforce the benefits of breastfeeding and address any concerns and emotional needs. Reassure mum that it's going to go back to normal soon. Antibiotics, the mainstay is flucloxacillin or dicloxacillin. The doses are down there. If they're allergic to penicillin, they can have Careflex or erythromycin, and occasionally we use clindamycin if they've got a lot of drug allergies. If there's no response after 48 hours, consider intravenous antibiotics and an ultrasound to exclude abscess, breast abscess. So just to keep in the back of your mind, there is a differential diagnosis of inflammatory breast cancer, and that's what it looks like in the picture there. That's what a breast abscess looks like. Happens in 3% of women with mastitis, and it's a hard lump which fails to resolve or enlarges after antibiotics have been started. It's diagnosed by ultrasound. We can use needle aspiration to get our organism and to partly treat the abscess. And in some small abscesses you can do recurrent aspiration as treatment. In larger, more complex abscesses you need to refer for surgery and incision and drainage under general anaesthetic. And the abscess will not resolve with antibiotics alone. The mum can continue to feed from the infected side after drainage, and if possible she should be kept in hospital, and a lactation consultant should assess and help her with a feed, and that's fine as long as the incision's not over the nipple area. Other causes of lumps, galactocele, which is thought to develop from a blocked duct, and it's just a collection of milk. It can be treated with aspiration, but it may recur. We probably don't have time to cover this, but I just thought it'd be nice to have a good set of notes that had everything in it. So I've just put some stuff in about persistent nipple pain. Just really latch is the message. Nearly everything is caused by poor attachment early on, and things like tongue tie in the baby are things that are important for us to recognise. So that's a picture of what nipple trauma looks like from a poor latch. And shallow latch, the easy things to fix is when the mum's putting in too much of the upper areola rather than the lower areola in the mouth. When the mother shapes the breast by angling the nipple upwards. When the baby pulls on and off with a blocked nose. And again, just tucking the bottom in close to the waist can help that. And if the baby has tongue tie and abnormal palate. Candida's another thing that people come in asking about. In reality, it's not as common as people think, but it can be treated with Dactar and gel on the nipple and in the baby's mouth. The women's have a really good handout on how to use Dactar and gel, and one of the things to know is that it says not to be used under 6 months on the product information, so you'll get a call back if you don't address that with the mother. PCR testing might be a bit more useful for identifying Candida when we're not sure. It doesn't show up that often on culture. So blocked ducts are treated similarly to mastitis. Occasionally it can be caused by a fatty blockage, and we actually see that in the Southern Highlands where it's really cold, and people can sort of squeeze out this worm-like thing that looks a bit like the butter coming out of a Vita-Brit. So sometimes a warm compress just before massage will help get rid of that. If you can see a white spot on the nipple, that's a growth of epithelial tissue over the top of the nipple paw, and it needs to be removed just by flicking it off with a little sterile needle. If the patient isn't at the doctor's surgery, they can try their fingernail or sometimes momentazone ointment. And just keep feeding and expressing to properly empty the breast once the blockage is cleared. Vasospasm's quite trendy at the moment, but it's actually reasonably rare in clinical practice. And mostly you can do that just by getting the mum to feed under a blanket, avoid caffeine and nicotine. But it can be treated with nifedipine provided the mother's blood pressure is not too low. And sometimes magnesium is suggested, and ibuprofen seems to help it a little bit. So they're my references, and I'd encourage you to have a look at what's on Health Pathways, and there's a whole lot of online resources there that you might find helpful to have a look at. Okay, thank you very much.
Afternoon tea session. Anyone got any questions before afternoon tea?
Yes.
If somebody is not breastfeeding, what would you suggest because of ecological problems, breasting, feeding, medication?
So this is a mother who's already decided to wean the baby and has no intention of feeding again?
Yes.
So you can use cabergoline, which is the drug name's Dostonex, and it's half a tablet 12 hourly for 2 days. And in that, the doses are all written down in that handout. There's a slightly different dose if the mother doesn't want to actually ever lactate. So someone who's had a stillbirth would have a higher dose, but that's available if needed.
People ask for bromocriptine.
We don't use bromocriptine anymore because of the side effects, so this one's safer. Yeah.
If a mother is breastfeeding from one side and expressing on the other side because of inverted nipple,
Yeah.
would you routinely offer the express milk?
Yes, I would. Yeah, but maybe not when they're out, but I would offer it just in case. But usually we can actually encourage the babies to feed from the side with inverted nipple. They just might not. They might always prefer to go on the other breast. That's all. Yeah. Yep. Down the front.
In your first, the case that you presented at the beginning, you just mentioned about finger feeding.
Yeah.
How does it go?
Okay. So one of the things that we try and do, if we've got a mother that we're worried the baby won't attach well, is to avoid giving it a bottle, because often once you've given the baby a bottle, particularly if there's an inverted nipple, and the baby will prefer the bottle then. So with finger feeding, essentially you have to order these in. You wouldn't routinely have them. The hospital might give you one if you ring and ask them. So it's a little 5-gauge French feeding tube. You just tape it to the mother's finger, and she just pops the finger in the mouth and just use a 20ml syringe. So you might, for that 60ml comp, she'd have 3 20ml syringes of express breast milk. And as the baby sucks, you just sort of slowly inject it as it's sucking your finger. But you can give express breast milk on a spoon. Babies will lap it off a spoon. You can put in little drops with a little medicine cup, and just by squeezing it and putting it in. So if you're not using large volumes, there's lots of ways to give a complementary feed. The supplementary nursing system is probably the best if you can get a hold of one, because then the baby's sucking at the mother's breast, and that's giving the same sort of stimulation as it expressing. So that's a good way to give it.
I'm thinking I might use a 25-gauge butterfly needle and cut up the needle.
Yeah, it's just that it's shorter. You could do it, yeah, definitely. But the feeding tubes are a bit easy to use, they're just longer. Yeah, and okay. Thank you very much. If anyone wants to ask anything specific, I'll be around at afternoon tea.